Welcome to Clinical Tools Library, evidence-based scales and questionnaires designed to support healthcare professionals in practice. The gross motor function measure assesses changes in gross motor function in individuals with neuromuscular disorders. It evaluates abilities such as lying, rolling, sitting, crawling, standing, and walking. The scale is specifically designed for use with children who have cerebral palsy and other conditions affecting motor skills. Its main purpose is to provide clinicians and researchers with a standardized tool to measure motor function progress over time. This facilitates treatment planning, outcome evaluation, and clinical decision-making. The gross motor function measure is supported by extensive validation studies demonstrating reliability and sensitivity to change. The gross motor function measure is indicated for children with cerebral palsy and other pediatric populations with motor impairments. It is primarily used to assess changes in gross motor function over time. The tool is valuable in clinical settings focused on rehabilitation and therapy planning. It supports evaluation of treatment efficacy and guides goal setting for physical therapy interventions. Evidence shows the measure has high reliability and validity for children aged 0 to 16 years, with varying levels of motor function severity. It is less applicable for adults or individuals without neuromotor disorders. The gross motor function measure consists of 110 items designed to assess gross motor function in children with cerebral palsy and other neuromotor disorders. The measure is divided into 5 dimensions: lying and rolling, sitting, crawling and kneeling, standing and walking, running and jumping. Administration requires observing a child performing a series of tasks that increase in difficulty. Each item is scored on a 4-point ordinal scale, ranging from 0, indicating the child is unable to initiate the task, to 3, indicating the child completes the task fully and independently. The assessor guides the child to attempt each task, providing necessary support only if required for safety or positioning. Scores for each dimension are summed and converted into percentages, reflecting the child's level of gross motor function within that domain. Interpretation involves comparing the obtained percentage scores against established reference data stratified by age and severity of motor impairment. Higher scores indicate greater functional ability. Reference ranges assist in tracking developmental progress or response to interventions. Consistency in testing conditions and scoring ensures reliability and valid comparison over time. The gross motor function measure demonstrates high sensitivity in detecting changes in motor function among children with cerebral palsy, indicating its strong ability to correctly identify those with true functional improvements or deterioration. Sensitivity refers to the proportion of true positives correctly identified by the measure, meaning the GMFM effectively captures genuine motor function changes. Specificity, which indicates the capacity to accurately recognize individuals without the condition or change, is also reported as substantial, though slightly lower than sensitivity in some studies. For example, in clinical assessments, a sensitivity of 0.95 suggests that the GMFM will correctly detect 95% of children who have experienced real changes in gross motor skills, reducing the risk of false negatives. Meanwhile, a specificity of 0.85 implies that 85% of children without significant functional change will be correctly identified, minimizing false positives. These metrics underscore the reliability of the GMFM in distinguishing true clinical changes from measurement variability in therapeutic and research settings. The gross motor function measure was originally developed in the early 1990s by Russell and colleagues as a standardized clinical tool to assess changes in gross motor function in children with cerebral palsy. Validation studies demonstrated strong psychometric properties, including high inter-rater and test-retest reliability, with intra-class correlation coefficients often exceeding 0.95 across the measure's dimensions. Construct validity was established by correlating gross motor function measure scores with established motor scales, motor milestones, and functional classifications, confirming its sensitivity to different levels of motor impairment. Subsequent research by Fowler and colleagues expanded the application of the gross motor function measure to populations with Down syndrome and traumatic brain injury, further supporting its predictive and evaluative capabilities. Factor analysis confirmed the measure's dimensional structure, aligning with theoretical motor development constructs, while responsiveness to clinical interventions was documented in longitudinal studies tracking changes over periods ranging from weeks to months. The measure's reliability and validity have been reproduced in multiple international studies, enabling its use in both clinical and research settings globally. Thank you for watching. For complete information and official PDF resources, visit clinicaltoolslibrary.com or check the link in the description below. And don't forget to like and subscribe for more clinical insights.